Adebayo Abe. Mr. Adebayo is a medical physicist at the College of Medicine, University of Lagos. He has about 14 years experience as a clinical physicist at the Department of Radiotherapy and Diagnostic Radiology, Lagos University Teaching Hospital. He has worked and consulted for various diagnostic centers in southwestern Nigeria. His main area of interest in medical physics is dosimetry, as well as the design and fabrication of QA accessories. So that is who will be speaking to us today. Mr. Abe, thank you very much for accepting our invitation. You can please share your screen and start your presentation.
Okay. Thank you, everybody. My senior colleagues, my teachers, my colleagues. My name is Adebayo Ade. So I will be talking on the total skin electron radiation treatment techniques. How best can it be clinically achievable? And I'll be speaking on all these outline, introduction techniques, dose prescription, dosimetry parameter and accessory, the QA program that is needed for total skin electron irradiation, and the clinical statistical results. That's introduction. The total skin irradiation treatment refers, as we call in many names, total skin electron therapy or total skin electron beam therapies. It has been referred as a special radiotherapy technique that aim to irradiate the patient's whole body or skin, while sparing all other organs from any appreciable radiation dose. This technique has been classified to be a complex one and time-consuming, even by IAEA or Association of APPM. The first application of ionizing radiation in this treatment of mycosis fungoides for whole body radiations was made in 1902. And that time it was on photons, but later the total skin electron treatment was initiated in 1950 for treatment of T-cell skin lymphoma and for treatment of Kaposi sarcoma due to the difficulty in radiating the entire skin. There are various techniques that has been employed and been modified. And I'll be talking about the few because the technique is being modified as we are getting more advanced technology. And these techniques, the first one was large electron feed techniques, where you open your feed from 40 to 40 in electron mode, and you try that the beam alignment was able to meet up with the patient height, and it can be done in two modes, positional mode. And the first one is sleeping standard position, and the second one is standing standard positions. Because of one beam being used under these techniques, to cover the height of the patient, at least you need SSD ranging from 5 meters, 500 centimeters to 7.2 meters. Then the second one is rotational techniques, in such a way that a physicist will have designed a rotating devices and also to calibrate it to the dose rate that been emitting from the NINAX. And you have, in such a case, you have also the SSDs greater than 5 meters. Then the third one techniques involving the patient shifting from positions. And in the mode, we have sleeping mode, standing mode, and also modify. And this one that Stanford designed, that we have a 6 position and standing, so that in order to cover the entire skin, I just give these pictures that this is one of the latest techniques being employed. You can see here that at first, this was done at a 0-degree angle, but the feed, because of the feed side from the window assist to the floor, is not sufficient. So the feed will not able to cover the entire size of the patient. Then he moved to the another orientation to extend. Move another orientation at the gantry of about slightly at oblique angle, and also to cover the side or axillary area. You can see this. It was this picture shows how the phantom of a patient, because you cannot be measuring your dose on the patient. So he tried to figure the patient pressure using the head phantom, body phantom here. So this is a sleeping technique mode. As I've said earlier, dual feed and single feed beam arrangement. The dual feed arrangement show more improvement on those homogeneities and more than the single film because of the long of SSD mode. And that's why that most of the patient plan on new techniques has been done on dual feed or multiple feed now. Those precision ever used on total, total skin electron irradiations. We have towards approfractionation where 4 gray is given in 6 fractions, but must be done once weekly. And this is good when you have all your QA program in place and you know that there are no chances for error or tolerance being avoid the tolerance being under the limited range. Then another form, we have a 4 gray in 3 fractions, but it has been shown that some patients that are treated in 4 gray in 3 fractions, some them do come back for recurrence. Then we have other conventional fractionations in such a way that the daily dose given between 1.8 to 2 gray. And this was done Monday to Friday. In our center, I think we employ among the patients we plan to be 1 gray daily, while we are covering from Monday to Friday. Then we also have elongated fractionation in such a way that the patient is receiving less than a gray or up a gray for in the course of the daily treatment. Then I try to show, because I've said earlier that the rotational versus translation techniques. Here in rotational mode, you can see from this image, there's a device we call a degrader. And the function of this degrader, which I'll be explaining later in the course of this webinar, is to bring the dose, the software to whip off the weak electron dose due to the long SSD value, and to make your follow-up dose to be reduced, because the aim is we are treating the skin, which is under a centimeter, between 2 mm to 1 centimeter is okay. Then in the transitional mode, we can see that in order not to avoid any underdose or overdose, the patient stands in 6 positional directions where we see the right anterior oblique feed and right direct anterior and left anterior oblique feed. Also, you can see right posterior oblique feed, direct posterior, and left posterior oblique feed. Before a center can treat successfully a total body irradiation or total skin electron, there are some list of accessories you need to have, and you need to commission it, that you need to get the precise dose on the skin, which I said we have anthropomorphic enhancing phantoms. You need to have a film as well, the praying parallel chambers, that you can see that I try to get the image. A spoiler is a device that always puts at exit of the NANP, because the electron that is coming out will have interacted with a lot of chambers, jaws, and the probable energies is more shallower. So when it's coming out, they put a spoiler at certain about 30 centimeters to even cause the electron to scatter more, so that you will be able to have a sufficient energy to travel further. And that's why we all need all this accessory. Then you need to get your leg shield as well, that is required for the gonal shield. If the patient is still younger and is a male, then the leg shield must be in place as well. And you need OSLD and TLD, which are the point where you get your beam alignment on the patient. Because of the large field that is involved, you don't want to underdose, so you try to mark a lot of area from the chest, from the midpoint of the navel, to know that the dose that is gotten there, which is 1 grade, that is it more or lower. So you have to have your TLD. And when you are positioning the patient, you have to beam and read your film, or if you are using a film or OSLD as well, to know that you are getting the precise dose that you are expecting at the plane or at the patient's skins. So these are the images showing the film, the lengths, this length sheet, and this is the gonal sheet created. And these are the OSL, for example. Dosimetry parameter that we needed, that your treatment feed side, you have to make your feed side at least 2 centimeter flash, at least, from the where the arm are spread to, and from the skull. Then the precise dose, the beam penetrated depth, the dose rate at the treatment plane. And because if your dose rate, for example, if your dose rate, most of the machine curve will be in the NANP, we have, it was 4 grade per minute, we have 400 monitoring dose rate. Then electron energy at the treatment plane. Then there are some area, that you need to boost. If in the course of the treatment you observe that it is underdose, then you should let your field flatnet treatment plane, you have to evaluate that, oh, it's another parameter to know that so far you are using a larger feed from the S1 and S2, that the dose between the extreme and the midpoint must be similar. That is, must not be less than 5% or 7%. Some 10% difference is allowed. You must get your patient positioning very well. Then X-ray background, which is photo contaminations, you need to evaluate those parameters as well. QA program needed. why the rigorous QA program is to evaluate the photon contaminations. Because when you put a spoiler, what you are saying, you increase the scatter and the electron energy being harder more. And you are, as a result of that, a degrader is needed. A degrader and a spoiler is just the same thing. But when you put it at the exit of the NAMP, you call it a spoiler. Then when you put it as 30 centimeter to the patient or less than, you call it a degrader because it will whip off the lower energy electrons. Then to evaluate those homogeneity, to evaluate those uniformity. Those uniformity will give room for the value of those homogeneity. Then to evaluate your dose accuracy. Okay, at 5 meter, if you are using a 1-fit technique, so that at 5 meter SSD, are you getting your dose that you are prescribed maybe in the 6 positional standing? Are you getting your 1 gray? If it is 1 gray, you prescribe for daily dose, or if it is 2 gray. Then also to evaluate the positional accuracy. That is when the patient is standing at directly posterior to the beam or at oblique positions. So you have to make that in maintaining odd position throughout the treatment days. That is how to evaluate by calculations. We say photoconductivity is those in the phantom at the depth behind the practical range divided by the treatment scheme. For example, if you are using a 6 electron bolt, we know that each NINA specified from the commissioning data, maybe your practical range or therapeutic depth may be at 1.2 or at 1.5. It depends on the commissioning data obtained from the machine. At that point, beyond the therapeutic depth or range, now you want to treat the dose that is gotten to the skin. We said D equal to 0. Then beyond that, where if a lot of X-ray background or contamination due to the degrader placed in the part of the beam, make the beam more harder. Then at a depth of 5 centimeter, some do it at 4 centimeter. What the value of those got there will determine the evaluation of your photon contaminations. Then a body factor is another factor, because in all directions and position the patient is standing in, like a Stanford position, it is designed that the patient should stand in 6 different positions. Then, and at the end of the day, you want to get the actual dose, either the one, because there may be a scatter from the oblique side of either from the right or from the left, but you are getting an actual dose to your as being prescribed if it is 2 gray or 1 gray. Then we see that for a feed, now for all the feed, will be the summation of the feed arrangement. You make the direct anterior, the direct posterior, the left, right oblique, all in 6 total, then divided by body factor, which is expected to be 6. If your patient is standing in 4 different orientations, you make it more than a 6 or a 4 or less than. So the body factor also will be expected to be number of the positional standing of the patient. Those calculations that involve the dose that should be given in a single, either the direct and oblique feed. Then in all feed orientations, the dose at the point that you are mentioning, either from the midpoint, either from the axilla point, will be, I'm just give that if we are considering a field orientation from those lateral multiplied by the body factors. Therefore, the dose accuracy must be determined from the comprehension of the dose measure and dose calculated. Because before the patient starts the treatment, it was the phantom that was used. Then on the first day of the treatment, you have to place either your film or your TADs to know that the one you get when you set up or when you simulate is not a computer tomography simulate now. The position of the patient must match with the one that you are delivering. And that's why the dose at any point are plain minus the dose at the midpoint, because the midpoint match the upper feed and lower feed if you are using a dual feed techniques. I decided to put this because I'll be talking about in our center the 4 patients treated. We did not use a degrader method because at that time we haven't gotten such techniques in place. But here it shows that when you use a spoiler or degrader, you have less photon contaminations. That is to say, you have a less shallow dose going beyond the skin. And this was just the Monte in red, and with the degrader and without degrader. If you see from the depth here, you can see 5. This is the 90% of the, which represent the practical range of the electrons. You can see here that the graph, the one that doesn't have a degrader, show more shallow dose. That is going beyond the skin more, which is not good enough. In our center, the field orientation use is a bit different from the one that's being recommended by the Stanford orientations. Being the fact that you don't have a rotating devices, then what we have is only plain parallel chamber. So we use direct upper anterior feed, direct upper posterior feed, and right upper lateral feed, left upper lateral feed, and direct. So while the patient is turning, when you want to do the treatment from the lateral point of view, I show the images here. That what I'm trying to explain, from here to, from this point, we give you upper anterior feed. Because most of the patients we see in our center, the fusion, the basal cell at stage 4, and we see that their palm is, we see the experience of the dilated skin, a pappus is also experienced. So we use this method in order to irradiate the palm very well. Because if you are using a rotator, the way the patient stands, as I've shown before, may be holding the supporting device of the patient. And as a result of that, we may underdose the area of the palm or of the wrinkle. So we call this one upper, yes, upper anterior feed, lower anterior feed. I just try to say that from the side way, because we match the alignment of the beam on the posterior lower posterior and anterior feet, we observe that our feet cover the feet and the leg very well. But at the upper feet, we observe that towards the axilla area, the anterior and the posterior being closer. So that's why we reinforce to give a lateral feed towards the upper feet of the patient in order to not to let any of the skin or the whole body to receive underdose. This is a sample of the setup. In our method, we decided not to involve, out of the 4 patients, we decided not to involve, we cut out the head, the skull area, and treat separately because of the how heavily the skin of the patient involved, and we give a booster dose to it. This is the where we are treating the whole body from the upper, then treating the head area alone. Then the feet area also was treated differently. From the summary of our dosimetric analysis, out of the 4 patient planned, our MU varies between 870 870 to 1,298 monitor units, because this is the monitor unit we got at the point of SSD on the plane. We will use to convert to achieve a 1 grade, and these are the various SSD used among the 4 patients treated. Then some patients were given a boost to elbow, buttock, palms, and feet, depending on the patient. And the various range of the boosters that were given, nothing less than 15 grade. The upper and the lower limit for point measurement was less than 8% of the precise dose. Sorry. 3 out of the 4 patients had a break due to the weakness, most skin discrimination, and machine maintenance. Then at 20 mm depth, photo contamination we obtain is less than 7%. Our clinical observation, we try to follow with the patient, because the most critical issue with the patient is the itching. Along the line, we observe to the 5 weeks with all the patients treated and confirm that the itching stopped virtually in 5 weeks. No radiation burns was noted in all our patients. We have been following up the patient up to 10 months without recurrence. I just put this because what we have in our center is a pain paralysis chamber, and we measure at different positions to get the value at the surface. Then when we put a phantoms of different size from our PPMA at depth of 1 mm, 2 mm, so we arrange to get our 7% that I've said earlier in our dose homogeneity. I use this because here we see that a lot of the probe was irradiated due to the last fit. So I compare when to cumulate. We cumulate from the exit of the window to this chamber air, and we compare the result. And we observe that the result is less than 3% or between the brain parallel and the self-calibration chamber we have at our center. This is sample of the patient treated. You can see here that the hand is heavily involved. Pupils, dilated skin. And after the treatment, this is before the treatment, and we can see that the whole skin was restored. And this is yesterday, we got from feedback of the patient. And all our patients, this is just a sample of vision, are doing greatly fine. Thank you very much. Hello?
Thank you. Mr. Abe, thank you so much. Wow, that was great. That was a lovely presentation. And thank you. First of all, thank you for keeping to time. Thank you. Please,
can I ask something before the questions? Can I ask something before the question? Okay.
Yes.
Thank you. Yes, you can see we have, because in our center, we have not fully commissioned our process, because you can see from my presentations that we don't have film. And when you are using a brain parallel chamber, it disturbs a sizable number of interactions. And if the NAMP or if other centers have a film, so we can fully commission based on each center or Nigeria. Because of recent, I read something online that Irradiation, maybe in 2021, they commissioned their total skin irradiations techniques nationally. Thank you very much.